Right, good afternoon, and welcome everyone as you pop in from the waiting room here. Welcome to this presentation on insights for patients and caregivers for navigating Medicare open enrollment. My name is Matt Shepard. I'll be moderating this session today, and we are very pleased to be presenting this in partnership with the Cures Collective today. Our various presenters from CMA and Cures are going to be the Center for Medicare Advocacy Co-Director David Lipschutz, Managing Policy Attorney Kata Kertesz, and Supervising Attorney Eric Krupa. They will be joined by IMALS Vice President of Community Support Aditi Narayan Minkoff, Cure MAPT FTD co-founder Linde Jacobs, and IMALS Manager of Community Organizing Julie Balasalle, all from the Cures Collective. And they will be engaging in a panel discussion a little bit later on in our presentation. Before we move on to our fantastic presenters, a little bit of housekeeping. As with any online presentation today, your audio and video connectivity are going to be at the whim of the internet. If you do have audio trouble, note in the audio section of the control panel and also on the confirmation email you got, there should be a way to switch in to dial in by phone. So we do have that option. Video, well, video's down to the internet. Should anyone have trouble watching and/or listening, though, note that all registrants will receive a link to the recorded presentation once it processes after we close out today. Another control of interest to many here, I am assuming, captions can be turned on by pressing the CC button at the bottom of your screen, should you want captions for the day. Very easy. Thank you, Zoom. Also, for today's presentation, we're going to keep this massive group of attendees. We had almost 3,000 registrants from every state in the country. Amazing turnout. Thank you very much for that. We're going to keep folks muted, obviously. That's a lot of voices. And also because of that turnout, we probably aren't going to get to every question when we have time for discussion and Q&A. But please do note that there is a questions button at the bottom of that control panel. You can hit that and it opens up a little field into which you can type your questions. And we will look at those. We also have the traditional chat. I see several people already in the chat letting us know who they are and where they're from, and that's fantastic. Love that. Please feel free to engage in that throughout the presentation. For those questions, though, we'll be looking at that questions panel. And in addition to any questions that our live attendees have, we received hundreds of questions and comments during the registration process, and I know that we're going to be trying to address some of the common themes from those as well. A little bit about the Center for Medicare Advocacy. I'm sure some of you have been reading ahead up on the screen there before we bring up Aditi to discuss the Cures Collective. The Center is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities by providing exceptional legal analysis, education, and advocacy, all based on the experiences of the real people who contact the center every day. And now, with much gratitude to all of our participating Cures Collective partners, an amazing group of organizations, let's bring up Aditi Minkoff to tell us more. Aditi.
Thank you so much, Matt, and good afternoon, everyone. My name is Aditi Narayan Minkoff, and as Matt mentioned earlier, I'm the Vice President of Community Support at IMALS, and I also lead the Cures Collective along with other members of our incredible steering committee. Many of you may know that neurodegenerative diseases are on the rise, and 1 in 4 people will be diagnosed with them. The World Health Organization estimates that they will become the second leading cause of death worldwide in developed countries by 2040, overtaking cancer. Yet not enough Americans know about neurodegenerative diseases like ALS, Parkinson's, MS, Alzheimer's, frontotemporal dementia, Huntington's, and others. And in addition to low awareness, there are also many barriers within the research ecosystem that are hindering our progress. The Cures Collective was launched in April of 2024 and is a coalition of multidisciplinary stakeholders united across the entire neurodegenerative landscape to amplify public awareness and accelerate scientific progress to unlock cures for all. We have almost 60 member advocates and organizations, and they are focused on increasing public awareness, on solving for the systemic barriers within the research ecosystem, streamlining community-based care and support for people impacted by these diseases, and mobilizing around protecting federal funding for research. If you or someone you know is interested in joining this work, please email me and I'll pop my email in chat so everyone has that, along with a link to the Cures Collective's current webpage, which also has a link to sign up for our newsletters if you are interested. And with that, I will turn it back to Matt with sincere gratitude to the Center for Medicare Advocacy for partnering with us in this initiative.
Thank you, Aditi, and to everybody in the Cures Collective. Needed more than ever right now. And I will hand things over to CMA co-director David Lipschutz, who will go over our agenda and get us started in earnest. David.
Thank you, Matt. Thank you, Aditi, and thanks to all of you for joining us today. Here's an agenda for the next hour and a half that we plan to spend together. I'm going to kick us off with a quick review of Medicare and the upcoming annual election period. I'm then going to move on to discussing various trade-offs between the two major coverage types in Medicare, Medicare Advantage and traditional Medicare. Then Kata will step in and provide some additional information about Medigap plans, and we'll begin our discussion of 2026 updates by outlining some of the Medicare-specific impacts of H.R. 1, the reconciliation bill. I'll then step back in and talk a little bit more about some of the updates for next year, including the Part D out-of-pocket cap. Eric will then provide some practical advice concerning choosing coverage options and navigating the Medicare maze, and he'll then cover some various types of assistance that might be available for beneficiaries. Then Aditi will lead a discussion to talk a little bit more about important considerations for people with neurodegenerative disorders and other chronic conditions, and then we'll turn to Q&A in the remaining time. Note that we have included far more information in the slides than we will have time to give complete attention to. We will touch on the main points, but we'll leave the rest for your reference, which includes some links to further information about what we're going to discuss. We will repeat some things, we will say some of the same things in different ways, and we will be unable to get to other things. As Matt noted, we appreciate all of your feedback and questions submitted during the registration process, and we'll do our best to address many of them during the course of this presentation. Here we go. Next slide, please. We're going to start with an overview of Medicare in the annual enrollment period. There are 4 parts to Medicare. We begin with a quick overview of the Medicare program, which covers over 68 million older adults and individuals with disabilities. Medicare is divided into 4 parts, parts A, B, C, and D. Parts A and B together form the core of the Medicare program, and together comprise what is known as original Medicare, traditional Medicare, also known as fee-for-service Medicare. We're going to refer to it as traditional Medicare for the bulk of the rest of the presentation. Traditional Medicare is really the default, and as we'll discuss more in the next slide, most people have Medicare plus something else which supplements Medicare. In the case of Medicare Advantage, replaces it. Part C is the Medicare Advantage program. It's the private plan option in Medicare through which people get their Medicare coverage. It's grown rapidly in the last couple decades and now has more than half of all Medicare enrollees. Part D is the prescription drug benefit that started in 2006. It's available only through private plans, either a standalone prescription drug plan known as a PDP, or from Medicare Advantage prescription drug plans. Medicare is not free, nor is it comprehensive. Most people don't pay a premium for Part A, but most people do pay a premium for Part B, which is about $185 a month this year. While lower income individuals can have assistance paying for this, as Eric will discuss later, higher income individuals pay more for Part B and Part D. Medicare Advantage premiums vary. Many plans are offered for 0 premiums. Part D premiums vary as well. And note that, as we will touch on later, we do not yet have the 2026 figures for Parts A and B premiums and cost sharing. They just have not been released to the public yet. Next slide, please. Our nation has a disjointed patchwork health insurance system that unfortunately is overly complex, confusing, convoluted, and complicated. Many of us here on this call and joining this webinar are working to change that. But this is the system we have today and the rules that we currently have to operate under. This slide alone can take a full hour to go over, but we will dispatch it with it rather quickly. Most people with Medicare, Parts A and B, also have something else. Nearly 90% have some other type of coverage which coordinates with or somehow fills in the gaps of Medicare coverage. Roughly 10% don't. Different types of insurance have different rules for how it interacts with Medicare coverage, if at all. Different rules as far as when you can pick it up or drop it. The general rule is that Medicare is primary to other insurance. With respect to employer-based coverage, there are specific rules whether or not Medicare or an employer plan is primary. That depends on the size of the employer, the age of the beneficiary, and whether or not someone has that insurance based on their or a spouse's, or in some cases, a family member's current active employment. When someone no longer has coverage through current active employment, through COBRA, for example, or retiree coverage, everything changes in the eyes of Medicare. And it's a huge pitfall and trips a lot of people up. People really need to pay attention when it comes to their employer-based coverage in Medicare. Medicare supplemental insurance policies, also known as Medigaps, are a way to supplement coverage for people in traditional Medicare, about which Kata will talk more a little later. There is certain types of coverage available through the military, the Veterans Administration, or VA. Medicare and VA coverage work independently of each other. TRICARE generally serves as secondary to Medicare. There is the Medicaid program, called different things in different states. It's a blend of a state and federal program for people who meet certain eligibility criteria. People can have full Medicaid, either with traditional Medicare, also with the Medicare Advantage plan. Also, there's a program through Medicaid called the Medicare Savings Programs, about which Eric will talk more later, that can help people who qualify pay for some of their Medicare premiums and potentially cost sharing. Medicare Advantage is a way that more than half of the Medicare population supplements their Medicare. It really replaces traditional Medicare as long as the individual is enrolled in a Medicare Advantage plan. Then, of course, Part D provides prescription drug coverage. And for those who qualify for certain criteria, there is a program called the Low Income Subsidy or Extra Help, about which Eric will discuss more later. Next slide, please. So if all of that is not confusing enough, there are different enrollment periods for different parts of Medicare, times during which people can enroll or make changes to their Medicare coverage. First, we're going to talk about Parts A and B, and then the next slide we'll talk about Parts C and D. There is an initial enrollment period for Parts A and B when someone is first eligible. Usually people will get Part A automatically unless they defer their Social Security retirement benefits. The general enrollment period is a period of time for folks if they miss that initial opportunity and they aren't entitled to a special enrollment period. There are special enrollment periods, most commonly when people have employer-based coverage due to their current active employee or that of a spouse and sometimes a family member. And these special enrollment period or SEP rights have been expanded in recent years. The takeaway message from this slide is really, when approaching Medicare eligibility, do your homework. Take stock of what you already have, what you might be entitled to, and don't put off important decisions. You can delay enrollment in Part B without a penalty only in certain circumstances when employer coverage is primary to Medicare. Next slide, please. Now turning to C and D enrollment periods. There are also enrollment periods that are applicable to Medicare Advantage and Part D plans. Both when initially eligible for Medicare. To get Part D, you need either Part A or Part B in order for you to get Part D. For Medicare Advantage, you need both Parts A and B. Highlighted in red is the reason that we're all gathered here today. The annual enrollment period that starts 2 weeks from today on October 15th, which we'll talk more about in the next slide. We're also going to touch on a more limited enrollment period that begins in January, that is only available to people who start the year in a Medicare Advantage plan. Note that there are also special enrollment periods available when certain things happen, when certain triggering events occur. Someone moves, they're duly eligible for Medicare, Medicaid, they experience some type of marketing misconduct to their detriment. The full list of those special enrollment period opportunities are available in that linked document. Note that the advice provided in this webinar regarding coverage choices generally applies to people who are first eligible for Medicare and trying to decide what coverage they want, and is also can be helpful for this annual exercise determining whether or not people want to make changes to their Medicare Advantage or Part D coverage. Next slide, please. So turning specifically to this annual enrollment period, also known as open enrollment or fall enrollment. As we enter the fall, we are now facing the annual rite of passage, during which we will all be overwhelmed with incessant Medicare commercials, sales pitches, stacks of mail regarding plan options and Medicare choices. During this time period, which runs starting 2 weeks from today, October 15th through December 7th, people can make changes to their Medicare Advantage and their Part D coverage. They generally cannot make changes to Parts A or B coverage. Other insurance, such as employer-based coverage, usually operates on a different time frame. And as we'll discuss further, there generally is no right to pick up a Medigap policy during this time. This period is really geared towards Medicare Advantage and Part D. If you're in a Medicare Advantage plan or Part D plan and do nothing during this time period, you will generally automatically roll over into that same plan if it is offered next year. Next slide, please. So we just want to flag here, it's worth noting that some people will get another bite at the apple. If you begin the year enrolled in a Medicare Advantage plan, you have an extra opportunity to make a switch in coverage with respect to your Medicare Advantage plan. You can switch MA plans, you can go back to traditional Medicare and pick up a Part D plans, but note, there is not a similar opportunity for people who are on traditional Medicare and have a Part D plan. In other words, you can't switch from a standalone Part D plan to another standalone Part D plan during this time period. Next slide, please. It must be said that there is not free movement between the different types of coverage options in Medicare. They are not equally available, namely between Medicare Advantage and traditional Medicare. Now, there are many factors that push people towards enrollment in Medicare Advantage, including the fact that many offer attractive extra benefits that they are able to provide with extra money that they get from the federal government. There are massive advertising budgets and agent and broker commissions that pay a lot more for Medicare Advantage enrollments than Part D or Medigap enrollments. An insurance broker from Arizona who's joining us today wrote in that agents are paid way more for Medicare Advantage plans, and there should be level commissions no matter what product a recipient chooses. I couldn't agree more. I wish those were the rules. Thank you for the comment. In many ways, it's a one-way street. Once you're enrolled in the Medicare Advantage plans, you can change to other Medicare Advantage plans. And while you can return to traditional Medicare on an annual basis, most people will not be able to pick up later down the road a Medigap plan, as Kata will discuss more. Some people's choice is already made for them. For example, many retiree union coverage is available exclusively through a Medicare Advantage plan. People with Medicare and Medicaid also either face incentives, pressure, or requirements to enroll in managed care plans. Next slide, please. Not only are there unequal choices, but the entire Medicare Advantage and Part D system is set up with the assumption that people act in their own best interest, do extensive research about their options, and choose accordingly, but this just doesn't happen. Every year, Medicare Advantage plans can change their premium cost sharing, coverage, and coverage rules. Part D plans can also make a number of changes. And in addition, the plans could decide whether or not they're going to continue for the next following year, about which we will discuss more later. This entire system, based on private Medicare Advantage and Part D plans in Medicare, assumes that everyone will actively compare plan choices and make optimal decisions for themselves, but most Medicare beneficiaries do not undergo such comparisons and do not even use Medicare's official resources like 1-800-Medicare, the Medicare.gov website, or the Medicare New Handbook. Most people, if they go through this exercise at all, say, that's it, I'm done, I'm not doing it again. And they just let themselves roll over into whatever plan might be available. This is understandable, but not advisable. So now, next slide, please. We're going to talk a little bit more about the trade-offs between Medicare Advantage and Part D. And we're going to focus on, next slide, please. We're going to focus on the disadvantages of Medicare Advantage enrollment. And we do this because you are far more likely to hear about all the advantages in all of the Medicare Advantage plan advertising through TV, radio, print, promotional events, agent broker sales pitches, in which the disadvantages are either downplayed or omitted entirely. It's not a matter, or might not matter for Medicare Advantage enrollees who don't need to use health services, but for individuals with chronic conditions, these factors are critical to consider. Neil from Rhode Island expressed concerns in registering for this webinar about older adults confused by ads touting Medicare Advantage plans. People rarely have all the information needed to make informed choices. Neil, I agree with you and wish it were different. Note the concept of choice promoted and celebrated when searching for an MA plan is promoted. But when someone's actually in a plan, people's choice about who they can get coverage from and what coverage they get faces far more restrictions. So looking at some of the advantages of enrolling in Medicare Advantage, it's the path of least resistance. You don't need to pick up a separate Part D plan or a Medigap. They generally offer lower premiums, which they're able to do due to the excessive payment they get from the federal government. They often or always offer extra supplemental benefits, which is a huge draw for people, often dental, vision, and hearing benefits, but they are not standardized, these supplemental benefits, and vary considerably. And unlike traditional Medicare, there is a requirement that Medicare Advantage plans have an out-of-pocket cap that all plans have to offer their enrollees. The disadvantages, we're going to talk a little bit more about the first and third bullets, provider networks and prior authorization. In addition, some costs can be higher in Medicare Advantage than they are in traditional Medicare. And when it comes to Part D coverage, it's take it or leave it. There's no cafeteria option to pick and choose which Part D plan coverage you want with a particular Medicare Advantage plan. And as Kata will discuss momentarily, there are concerns about the ability to later pick up a Medigap. So last couple of points on comparing these two, provider networks and prior authorization. Next slide, please. In traditional Medicare, one can see any provider you want in the country that is willing to take you. Medicare Advantage plans, however, as a cost-saving measure, can generally limit who you see. Some plans have more open networks and allow you to see providers in other areas, but this can vary considerably. For individuals with chronic conditions, seeing the right providers, including specialists, is often critical for treating your condition, including maintaining or slowing deterioration. More and more providers, health systems are walking away from Medicare Advantage plans because of frustrations with wasted time and denied care due to prior authorization and lower reimbursement rates. Just because your key provider or providers currently contract with your Medicare Advantage plan is no guarantee that it will continue to be so. Just because you're in a PPO that allows you to see folks out of network is no guarantee that the provider will actually see you. An occupational therapist from Florida who is joining us today states, I feel most people do not understand the difference between regular Medicare and Medicare Advantage plans, especially if they are in need of care, such as therapy and other ancillary services. This is absolutely correct. There are even problems when people do their due diligence and try to see if providers are part of their networks. Beware of ghost networks. And what I mean by this is oftentimes providers are listed in a plan provider directory who don't actually contract with the plan or aren't taking new patients. And this is particularly the case when it comes to accessing mental health services. Eric's going to talk a little later about plan finder developments regarding provider networks. And then finally, next slide, please. Medicare Advantage prior authorization. This is a process that plans use to try to make sure that the care that is provided through a plan is medically necessary, not unnecessary or wasteful. It's meant to weed out unneeded care. The flip side is that it also weeds out necessary care. And while traditional Medicare has very limited prior authorization, which we will touch on later, nearly all Medicare Advantage plans use it extensively, particularly for higher cost items and services. A recent KFF study here quantifies how often it is used, and an Office of Inspector General study cited here tried to quantify how often it is used inappropriately. Now, this whole phenomenon of prior authorization appears to have gotten worse in the last few years, despite the Medicare program's efforts to try to manage this a little bit more. In short, prior authorization can be a major barrier to care, particularly for those with chronic conditions. One takeaway is that if you are in a Medicare Advantage plan and have care denied that you believe should be covered, we suggest that you fight it and appeal. And while few people appeal, when they do, many are successful. At this point, I'll turn it over to Kata, who's going to focus a bit on Medigaps and then start our discussion of 2026 updates.
Thank you, David, and hi, everyone. As David mentioned, I'm Kata Kertesz, and I'll be talking about Medigap plans. But first, I would like to just give a snapshot of the financial background of most Medicare beneficiaries, as it puts the discussion of the need for supplemental insurance into context. In 2019, half of all Medicare beneficiaries had incomes below about $30,000 per person. A quarter had incomes below about $17,000 per person. Half of all Medicare beneficiaries had less than about $74,000 in savings per person. A quarter had below $8,500, while 12% had zero savings or were in debt. And in 2016, the average Medicare beneficiary spent over $5,000 in out-of-pocket costs for healthcare. That's including premiums, cost sharing, and expenses for services not covered by Medicare. Beneficiaries without supplemental coverage were more likely to have lower incomes and be age 85 or older and had out-of-pocket costs over $7,000. It's also important to note that income, assets, and costs are also varied based on age, sex, race, and also for Medicare beneficiaries under the age of 65 with permanent disabilities. Next slide, please. So Medicare supplement insurance, commonly known as Medigap, is an optional form of supplemental insurance. It's offered by private insurers to help pay for the out-of-pocket costs that beneficiaries face. These can include deductibles, copayments, and other out-of-pocket costs. Medigap insurance typically only covers services that Medicare has already approved for payment and generally does not pay for excluded or omitted items and services in traditional Medicare. Private insurers selling Medigap plans in most states may only sell consumers standardized policies identified by letters A through N, and there's more information on the plan types and which one might be the best fit for certain types of beneficiaries in a later slide where we have additional resources. Medigap policies help protect beneficiaries from unexpected high healthcare expenses. It also provides beneficiaries the ability to more precisely budget for their healthcare costs. The rights to purchase plans, as David alluded to, is really limited, and I will get into more detail on that in a moment. Premiums can vary. Pricing can be community rated, issue age rated, or attained age rated. Next slide, please. So what are these rating systems? Community rating means that insurers must charge all policyholders within a given plan type the same premium without regard to age, and this is only for those age 65 and older. Without regard to age or health status. Issue age rating is when insurers may vary premiums based on the age of the policyholder at the time of purchase, but cannot increase the premium automatically in later years based on age. While attained age rating is where insurers may vary premiums based on the age of the policyholder at the time of purchase and can also increase premiums for policyholders as they age. For all different types, insurers can still adjust premiums based on other factors like smoking status. Because community rating does not allow premiums to be based on the applicant or policyholder's age or health status, it provides the strongest consumer protection. Attained age rating, on the other hand, allows premiums to increase as beneficiaries age. So these are often set at really attractive lower rates and then can increase quite dramatically. Next slide, please. So as David mentioned, we got a lot of questions in the registration form, and we thank you for all of those. We got a lot about Medigap specifically. Maria from California to Gloria in Pennsylvania and Robert in Michigan and a lot of other folks asked about Medigap access. And so I will walk through the consumer protections that exist and what is lacking. So for those over 65 is where we'll start. Medigap insurance is generally regulated at the state level, but federal law does require insurance companies that sell Medigap policies to abide by certain minimum consumer protection requirements for those over age 65. Insurers are required by statute to provide a one-time 6-month open enrollment period for Medigap policies that begins on the first month that a beneficiary is 65 or older and elects Part B coverage. During this period, these beneficiaries must be guaranteed issue of Medigap plans, regardless of their age, sex, or health status. Medigap companies must sell an individual a policy at the best available rate, regardless of health status, and they cannot deny coverage. If you're enrolled in a private Medicare Advantage plan for the first time, then individuals can only have access to a Medigap plan if they switch to traditional Medicare during their first year in the Medicare Advantage plan. This is called the 12-month trial period. A few states, Connecticut, Massachusetts, Maine, and New York, have expanded access to Medigap beyond the federal requirements. Outside of these states and beyond the limited qualifying events, such as an MA plan terminating, most Medicare beneficiaries are required to purchase Medigap when they're first Medicare eligible or during this 12-month trial period, or they may forego Medigap protections altogether. The reasoning for this on the market side is that it keeps the Medigap risk pool more balanced with both healthier and sicker individuals. There has been research that has shown that beneficiaries who are enrolled in Medicare Advantage and then become sick do exit traditional Medicare at a higher rate when they have Medigap beneficiary protections available to them. However, this market stability that's created by limiting enrollment comes at the cost that when beneficiaries become sick and they most need the comprehensive coverage, they may be priced out of Medigap or just denied coverage altogether. Next slide, please. So even these very limited federal consumer protections for Medigap policies for those over 65 do not apply to those under 65. In fact, individuals under 65 who become eligible for Medicare due to permanent long-term disabilities have even fewer protections. Insurance companies may deny coverage for this population completely for Medigap plans. Insurance companies are not required to guarantee issuance of policies to these beneficiaries, and they can freely deny coverage due to age, sex, and health status. Many states have, though, elected to voluntarily extend protections to their under 65 population. So currently, 34 states grant some degree of protection to those with disabilities and end-stage renal disease in their Medicare population. Insurers can often charge much higher premiums, though, based on health status. There's a historical context for this exclusion. When the exclusion in Medigap protections for beneficiaries under 65 with disabilities was created, many Medigap policies covered some prescription drug costs. Insurers were concerned that higher drug spending among Medicare beneficiaries under 65 when compared to the over 65 population would really drive up insurance costs, and that would result in higher premiums for everyone. But now this is moot because Medigap policies sold today are prohibited from covering prescription drug costs since Medicare Part D, established in 2006 that David just talked about, provides prescription drug coverage. And Medicare per capita costs, excluding Part D spending, is pretty much the same for younger beneficiaries with disabilities and those over 65. So the whole reason for the exclusion really doesn't hold true anymore. Next slide, please. So now I'll address some of the necessary Medigap reforms. Consumer protections that would promote health equity include making Medigap available to all individuals in traditional Medicare, regardless of pre-existing condition or age, and setting premiums at the same rate for all beneficiaries, including those under 65. Expanded enrollment opportunities like an annual enrollment period, similar to the one in Medicare Advantage, or continuous enrollment, should also be explored at the federal level. States have taken up this issue and some have expanded access in varying degrees. Legislation has been introduced in Congress in the past, though it has been unsuccessful, but it aimed to address many of these shortcomings in consumer protections at the federal level, so it would apply to all states. A few of them are listed here. Of course, we at CMA, in conjunction with our advocacy on Medigap, have also advocated for a maximum out-of-pocket cap in traditional Medicare. If that maximum was a reasonable amount, that would go a long way toward increasing flexibility for beneficiaries to switch from Medicare Advantage to traditional Medicare when they needed to. Some proposals in the past have included a $6,000 out-of-pocket cap. And again, looking back at the financial background of most beneficiaries, that's really just too high to make it possible for people to switch. So it really needs to be a much more reasonable cap. And the key to generally policy solutions in this space is finding the balance between the access to care, but also maintaining market viability, because we don't want to have dramatic increases in premiums for all enrollees in Medigap plans. Next slide, please. Here we just have a lot of additional resources on Medigap, including the last one is the one that I had mentioned earlier that includes specific plans in the A through N and which one might best serve your needs. Next slide, please. Now we'll turn to our 2026 updates, and I will mention our recent health legislation before turning it over to David. Next slide, please. So as most of you probably heard, on July 4th, President Trump signed the Congressional Republican Budget Reconciliation Bill into law. It's also known as the One Big Beautiful Bill Act, or OBBA, or HR 1. We refer to it as HR 1. It had projections of cutting Medicaid and ACA by $1 trillion, cutting healthcare for about 15 million people, and raising costs for millions of people. Of course, this legislation will have huge impacts on Medicaid, but it also had impacts on Medicare. Though Medicare was not the primary target of the legislation, its cuts will still be felt by Medicare beneficiaries. And I will just highlight two of these quickly. Next slide, please. The legislation included blocking a final rule that would have required states to improve enrollment and access to the Medicare savings programs. Eric will outline what these programs are in a moment, but I will just flag that these programs are an essential lifeline for dual beneficiaries struggling to afford out-of-pocket costs in Medicare. So that it is for the lowest income Medicare beneficiaries. The final rule was designed to increase enrollment in these plans for eligible beneficiaries, with CMS projecting that it would increase enrollment by nearly 1 million people. The Congressional Budget Office estimated that blocking the rule in HR 1 will save over $66 billion over 10 years. And the reason it saves money is that it prevents eligible beneficiaries from accessing programs that are designed to make Medicare more affordable. Because the legislation only blocked implementation of federal requirements for states to implement the changes, states can still move forward with the changes in the rule. So this is a really great opportunity for state advocacy to encourage enrollment in the Medicare savings programs. Next slide, please. So HR 1 also included immigration provisions directly impacting Medicare beneficiaries. This is the first time in the program's history that Medicare coverage has been stripped away from an entire category of eligible individuals, and the first time Social Security eligibility has been decoupled from Medicare. This slide and the next one provide more details on exactly which immigrants are affected. This is an issue we're monitoring closely, and we've written about this on our website and provide updates pretty regularly on our CMA alerts. So please continue to follow those if you are looking for more information on this topic. And with that, I'll turn it back over to David.
Thanks, Kata. Next slide, please. So Kata just talked about the impacts of a major bill that passed this year. I'd like to turn to a bill that was passed a few years ago, the source of the biggest changes to prescription drug coverage in Medicare since Part D was created, the landmark Inflation Reduction Act of 2022, or the IRA. It made a number of changes, including granting the Secretary of Health and Human Services the right to negotiate the prices of certain prescription drugs. Now note, the HR 1 bill that Kata just discussed did add additional hindrances to drug price negotiation, but overall, the program is continuing. The HR 1 limits, further limits rather, the ability of the Secretary to negotiate the costs for certain orphan drugs. Okay, so the IRA also imposed a number of other changes, including the out-of-pocket cap, which we'll talk about on the next slide. But right now, I want to flag for you the thing that's highlighted here, the link for the Medicare Prescription Payment Program. A lot more information about that is available through this link, but the bottom line is that this provision allows individuals to spread the costs of their drug over the course of a calendar year. It's a voluntary program, and it might not be the best option for everyone, though. It tends to work better for people who have high drug costs early in the year. We suggest you explore the trade-offs. It's probably much better if you end up qualifying for the Part D Low-Income Assistance Program, or LIS. Next slide, please. So as a result of the IRA, this is what the standard Part D benefit looks like. These are the 2026 figures. Among other things, it streamlined the program. There's no longer a confusing donut hole or gap in coverage that was closed by the Affordable Care Act, or a remaining period of coverage where it was confusing as far as who was paying what in cost sharing. Now, this is the benefit. It's much more straightforward. There is a deductible. Next year will be $615. Once that's met, coverage kicks in. Beneficiaries are responsible generally for 25% of the costs of coverage up until the out-of-pocket cap is reached. For this year, 2025, that out-of-pocket cap is $2,000. Next year in 2026, it's going up $100, so it'll be $2,100. This out-of-pocket cap is hugely impactful for people with high drug costs, and it brings Part D in line with most other insurance. What counts towards the cap? It does include that $615 deductible. It does not include Part D premiums and does not include drugs that are not covered by your Part D plan. Now, this is the basic benefit. Most plans are alternative plans or enhanced plans, meaning they have to provide something at least as good as this, but they have the flexibility to do more and, for example, lower the deductible or lower the amount of cost sharing, and can sometimes cover drugs that are not covered under Part D. Part of the reason why nuance matters, and it's important to look at the individual plans available in your area. Next slide, please. And finally, I'm going to end my part by doing a very quick run through of some other changes that are taking place or in the near future. As mentioned earlier, we do not yet have information about Part A and B premiums or cost sharing amounts. A ship manager from Colorado, I know specifically, signed up for this webinar hoping to have that. I looked back at when this information became available in the last 3 years. For 2023, it was available by September 27th. For 2020, in 2023, it became available on October 12th, and last year it didn't become available until November 8th. So we have no idea. That's kind of a wide range of time within which CMS can put this information out, but it would make the most sense to have it before people make enrollment decisions, clearly. What we do have information about, effective today, are the plan offerings for 2026, the Medicare Advantage and Part D plans. Information became live and is now available on the Medicare Plan Finder. While we have not had time to really analyze it yet, we are aware of some general trends, including that some of the bigger Medicare Advantage carriers are pulling out of certain areas. United Healthcare, Humana, CVS are pulling out of certain regions, certain counties. Plans are obligated to inform their members by tomorrow, October 7th, about these changes. Some plans will be terminating. Many of those affected might be shifted over into other plans offered by the same plan sponsor if they do not choose another plan on their own. Pay very close attention to any notices that are coming out from plans that are cutting back, because these terminations or cutbacks very often yield Medigap guarantee issue rights. In other words, certain rights to purchase a Medigap plan are usually triggered when plans pull out of certain areas. So pay attention to that. A couple other notes: Medicare supplemental benefits. It's a huge draw for people, as noted earlier, to enroll in Medicare Advantage plans. But a lot of information that we have suggests that a lot of people aren't really using a lot of these extra benefits. So the Medicare program issued a rule that was to be effective next year that would require Medicare Advantage plans to notify their enrollees about what unused benefits people had. We learned just a few weeks ago that this rule is being suspended indefinitely. There's another rule that limits the scope of supplemental benefits, basically for things that are not good for you, which makes common sense. We got a lot of questions about the WISER model. This is a demonstration in traditional Medicare that employs prior authorization for a certain number of services. I meant to mention 6 states here on this slide. I inadvertently omitted the state of Ohio. So the states are New Jersey, Ohio, Oklahoma, Texas, Arizona, and Washington. There's limited prior authorization in traditional Medicare right now, usually for some outpatient services and certain non-emergency ambulance services and certain durable medical equipment. There's a demonstration that's rolling out next year in these 6 states that expands the lists of services that are going to be subject to prior authorization. If you follow that link, you'll find out exactly what services those are. Part of the concern is that firms that employ algorithms or AI that have a financial incentive on the outcome of whether or not things are covered are suddenly being injected into the system. And we know from our experiences in Medicare Advantage that this does not often bode well for beneficiaries. Note that this list of states can expand along with the list of services that are subject to it. It's something definitely to watch for. More information is available through these links, and a number of advocates are trying to address this. Finally, Medicare.gov accounts as of last month in September. Now, in order to sign up for a new account, people have to provide email addresses. We know not everyone has an email account. Check out the CMS tip sheet linked here for setting up these new accounts. Also know that SHIP programs, state health insurance assistance programs, have received guidance about how to help people in this situation. Something else of concern to folks is that yesterday was the last day that Social Security sent out paper checks. According to Social Security, about 1% of the population still receives paper checks. They have certain suggestions in this guidance linked here about what to do if you're in that situation. In the interest of time, I'm going to pass it on to Eric next. But when we get time for Q&A and discussion, I think the fact that our government is shut down is worth mentioning. So we'll circle back to that. I'll pass it now on to Eric for some practical tips.
All right. Thank you, David. Good afternoon, everyone. It's good to be here with you all. And I do want to thank our friends at the Cures Collective for co-presenting with us today. They are going to be hopping on here just after my section, so in about 15 minutes or so. Looking forward to hearing all that they have to say. But for this section, practical tips, I'm just going to go through really some tools you can use in making individual choices about enrollment. So there's no one-size-fits-all advice that I can give everybody that will get everybody enrolled in the same plan. That's the best plan. It obviously depends on your situation and the medical costs that you're going to be incurring in any given year, or your anticipated costs. So I think with that, it makes sense to start with the annual notice of change, or the ANOC. You may be going into this enrollment period feeling relatively satisfied with your current Medicare setup, but know that it's not guaranteed to stay that way, as David mentioned earlier. Medicare Advantage Part D plans may change for the upcoming 2026 year. How will you know this? The annual notice of change, or ANOC. So you should have received this notice already. It's due to be received by September 30th, or yesterday. So you should have received it either via mail or email, depending on how you've elected to receive information from your plan. If you didn't receive it, probably time to reach out to your plan and ask for a copy of the information. And what information does it provide? It specifies exactly what's changing about your current plan, your Medicare Advantage, your Part D plan for the 2026 year, including any network changes, premium changes, benefit changes, drug formulary changes. And then it's also going to tell you where to find some additional information online. So you shouldn't expect, for example, to receive a full drug formulary for 2026. Rather, it will specify what changes are being made and then give you links to receive full plan information online. If you don't make a new election during the AEP, the annual enrollment period, you're automatically going to be renewed in your current plan as stated with the changes on the ANOC, if that plan is still being offered, right? So if your plan is not renewing, as David just mentioned, there are some significant changes expected as far as availability of coverage from certain plans in certain parts of the country. If your plan is terminating, not renewing, consolidating, you're going to receive a notice from the plan about how this is going to affect your enrollment. It's not the same effect in every situation. In some situations, you're automatically going to be switched to a different plan that's offered. In another situation, say you're in a Medicare Advantage plan in 2025 that's not renewing, and the plan carrier doesn't have a plan it can move you to, you're going to be switched back to original Medicare for January 1st. And that's important because if you're switched back to Medicare, original Medicare January 1st, and you haven't made any other changes, you're going to be without drug coverage and you're going to be facing higher out-of-pocket costs without a Medigap plan. So it's really important to be proactive if there is that termination or non-renewal of your current plan. And then the last bullet point on this slide here is just a link to information that you should be receiving from your plan on a yearly basis. It has the notices you'll be receiving from your plan each year and when you should expect to receive them by. Next slide, please. All right, so if you're considering making a change, how do you sort through the options that you have? The place to start is the Plan Finder, Medicare.gov's Plan Finder. It's essentially a search engine that helps you compare information on Medicare Advantage and Part D plans available in your zip code. So we had a question that was from Debbie in Pennsylvania asking, how do I know the cost of my prescription drugs for the upcoming 2026 year? A great place to start is the Plan Finder because you can have your list of prescription drugs, your preferred pharmacy, put that information into the Plan Finder, and it will spit back at you the cost for you of available Part D plans. So that's a good tool to be aware of that the Plan Finder offers. But in addition, it offers information on premiums, coverage, cost sharing, supplemental benefits, really everything you need to compare different plans and choose an option for the 2026 year. But admittedly, there can be a lot of information. It can be hard to navigate. It can be hard to know what's important. So if you're having trouble with the Plan Finder, if you want to talk to somebody about your options, we are always referring people to their State Health Insurance Assistance Program, or SHIP, for local expert, unbiased advice and assistance. So SHIP counselors, they're trained, they don't receive commission, and it's really unbiased, individualized advice that's going to help you make the best decision possible for you. We have a link here. Use this link. You'll be able to find your local SHIP, call them early because they do reach capacity. They're understandably very busy at this time of year, and they are relatively limited in the resources that they have, unfortunately. But they do make, they do a lot with the limited resources that they have. As a secondary option, 1-800-MEDICARE is always available too for questions on differences between plans. And like SHIPs, they can actually make the switch for you, enroll you in a different plan for the upcoming year. And then I'll mention this a couple times throughout the presentation, but it's important to reiterate, never shop by premium alone. The cost you're going to have for the full year is not just your premium, right? There's a lot of other costs to consider. Your deductibles, your co-insurance, your co-payments, all of those things are going to equal total out-of-pocket costs for you throughout the year. So it doesn't just come down to the premium when comparing plans. Next slide, please. All right, and as David mentioned, there are some changes to the Plan Finder. So as you're going through this, if you've used it in years past, you may see some additional information. In August of this year, CMS released a memo on enhancements to the Plan Finder that includes an extended display of supplemental benefits, a special needs plan filter, and maybe most interesting, as David mentioned, an MA provider directory. So information on what providers are in network for each individual MA plan. Hopefully these changes are going to be helpful for beneficiaries, but know that there is some anticipated challenge in making sure that all of the information is accurate with it being rolled out relatively quickly. So there is going to be a special enrollment period for beneficiaries who receive bad information through the Plan Finder when it comes to that directory information. So this is a temporary special enrollment period for 2026 calendar year. If you use the Plan Finder, you end up in a plan that you thought had different network than it does, call 1-800-MEDICARE and ask for a special enrollment period. Next slide, please. All right, and one thing to mention, important thing to mention when it comes to the supplemental benefits are flex cards. This is in particular an issue when it comes to DSNPs because they're offered in a majority of DSNPs. But in addition to other supplemental benefits like dental coverage, vision coverage, plans may be offering flex cards, which is essentially a preloaded debit card for beneficiaries to use on various expenses. And the data does suggest, as it said here in the slide, that it is particularly enticing for beneficiaries. People tend to cite it as a reason that they choose one Medicare Advantage plan over another, the availability of a flex card. Obviously, it's a good thing to have. Additional money in your pocket's never a bad thing, but it may not be as good as it seems in that if it's used for certain expenses, it could lead to you incurring more expenses. Specifically, if you're using that flex card for rent or utilities, your rent will be increased if you're receiving HUD rental assistance. Unfortunately, we've also heard from multiple beneficiaries who use the card properly, not for those expenses, but face a rental increase illegally anyway, and then have to deal with their landlord and try to get that rental rate adjusted per the HUD guidance that we cite here. But if you do use it for rent or utilities and you receive HUD rental assistance, you should expect an increase in rent and when using that flex card. Next slide, please. All right, and this isn't so much an enrollment slide as something to consider when choosing between Part D or prescription drug plans. As mentioned earlier, different Part D plans do have different formularies, right? So not all plans offer the same drugs. If a beneficiary finds themselves in 2026 in a plan that doesn't cover a medication that's medically necessary for them, there's the possibility of an exception request. So for example, if you have a drug that you need to take that's not on your plan's formulary, you can call your plan and ask how to make an exception request. And if you have a written statement of support from a physician saying that no other drug is medically sufficient, it may be possible to get that drug added to the formulary, though it might be at the highest cost of all drugs on the formulary. So I just want to mention that as if you find yourself in 2026 with insufficient Part D coverage, you may have options to try to get lower cost drugs. Next slide, please. All right, and with these next three, I'm just going to breeze through these three. Really, it's information that you can refer back to as you're sorting through your options. The first slide here, factors you should consider when making a change. Really summarized again, it's not all about the premium, deductibles, what drugs are covered. Are you going to be able to receive all the services that you anticipate needing throughout the year? What is the provider network? All of those things need to be considered when you're enrolling in a plan for any given year. Next slide, please. So this slide, a reminder of what David said earlier. If you have coverage other than Medicare, there are complicated rules on which of those coverages is going to be primary. Enrolling in Medicare when you already have coverage could affect that other coverage. So if you have preferable coverage through a retiree health plan, VA, TRICARE, COBRA, federal employee health coverage, what we advise doing is calling the benefits administrator and asking to have a conversation on if I enroll in Medicare, what happens? Next slide, please. All right, and this one is just a list of questions to ask yourself as you're going through making a decision. The only one in particular I want to highlight is number 7. What is the value of extra benefits like vision, dental, and hearing? And remember, just because you have dental coverage, just because dental coverage is offered through a Medicare Advantage plan or vision coverage, that doesn't mean it's good coverage. It's important to read the fine details. Is this just going to pay for a couple of cleanings a year? What's the deductible? All of those questions need to be asked when you're looking at that supplemental benefit of vision or dental coverage. Next slide, please. All right, Medicare Advantage agent broker do's and don'ts. So here we have linked, hopefully this link works here. If it doesn't, I can put something in the chat later. Many people work with a broker when they're sorting through their options, and that's perfectly fine. But in many situations, it's not appropriate for a broker to be soliciting you as a new client. It's really up to you whether you want to reach out to a broker for more information. So this document that we've linked here provides some information on when a broker should and shouldn't be contacting you. And if you're experiencing any issues, we have a number you can call in the next couple of slides here. But the other thing I want to mention, and we did get a topical question from Krista in Colorado asking this. There's been a lot of news recently about changing broker incentives. So how are those changing broker incentives going to affect how a broker is advising me for this upcoming year? So in Connecticut, for example, we're hearing from a number of beneficiaries who have been told by brokers that certain plans are leaving the state, when in fact, those plans are just eliminating commissions for brokers. So that's the major change that we're seeing is certain plans don't have the commission associated, making certain brokers more reluctant to sell those plans. So what we recommend doing, you may have seen this news in your area, is just having that conversation with your broker, right? Is there a change for certain plans with your payment or your commission? Are you still willing to sell me those plans? Depending on that conversation, you may wish to turn to somebody else, or you may feel comfortable continuing to have that relationship, continuing to work with that person. Next slide, please. All right, and this is just a summary of what I've discussed so far. Compare your options, get the assistance of a trusted professional, ship counselor, a trusted broker, a family friend who's familiar with this, who's sorting through their own options. Always talk to somebody when comparing your options. And then be mindful that the main reason for health insurance is access to quality healthcare when you need it, right? So you can't anticipate all of your needs for 2026. But what are your anticipated needs? And then if something were to happen, what plan is going to give me the best coverage in a time of need? And then take advantage of reviewing the annual or ANOC, annual notice of change, and really take this opportunity in the annual enrollment period to compare your options and make a decision that's going to be best for you for 2026. And then as mentioned, if you're feeling pressured in making a decision, we recommend contacting the Senior Medical Patrol, which is a program that you can report suspected fraud, waste, and abuse to, unfair marketing practices. We have a link here to their website. You can be connected with a local person or a number to call who can also connect you to somebody who can help you sort through that if you're feeling like you're being pressured in any way. Next slide, please. And so finally, we are running a little low on time here, so I'll go through these slides quicker than I would like to, but I want to talk about some ways to make Medicare more affordable. Next slide. So the Medicare Savings Program, this is going to help with Part A and B costs, things like premiums, deductibles, co-payments. What it comes down to is looking at these numbers here, 1,781 for a single person monthly income, 2,400 for a couple. If you're below that income limit, or if you're near that income limit for the upcoming year, you're going to want to call your ship and ask to be screened for the Medicare Savings Program, because it could lead to very significant out-of-pocket cost savings for you. Next slide, please. And so that was A and B. As far as savings for prescription coverage or Part D, that's the Extra Help program primarily. If you're enrolled in the Medicare Savings Program, you're going to be automatically enrolled in the Extra Help program. That's also referred to sometimes as the Low Income Subsidy Program. And like the Medicare Savings Program, it's going to help you with out-of-pocket costs. So we always recommend getting screened for the Medicare Savings Program first, because it's more accessible generally than Extra Help. But you should also be asking to be screened for extra help if you're around that income threshold mentioned on the previous slide. And then there are state pharmaceutical assistance programs available, SPAPs. We have a link here. You go to this link, put the state you're in, and it will tell you whether or not there is an SPAP that's available for you. That's wraparound coverage for Part D, which is essentially helping you with costs not covered by Part D. And then finally, the PAN Foundation has this excellent resource, the Fund Finder, which helps you find financial assistance programs or options for out-of-pocket prescription costs from a wide array of charitable foundations. Next slide, please. All right, and finally, a lot of people talk about GoodRx, cost plus drugs, those types of cost assistance programs. Those can be helpful. You may find that even with coverage, cost through those programs is less than it would be, but know that it can't be used in combination with your Part D coverage. If you do elect to use one of those programs, then you're going to be paying the cost under that program, and what you pay isn't going to count towards your yearly out-of-pocket threshold. So that's worth noting. And with that, I think I'm all set, and I'm going to be happy to turn it over here to the Cures Collective. Thank you, everyone.
Thanks, Eric. So welcome back, Aditi, and our panelists from Cures, Julie
Thank you so
Balasalle.
much, Matt.
And have we lost one of our panelists here?
Unfortunately, yes, she did have to step away for personal reasons, but this is going to be a fireside chat instead of a panel today. And thank you all so very much. That was just an excellent presentation by David, Kata, and Eric. Thank you for simplifying as much as possible the very complex Medicare system for all of us. And with that, I'd love to start, Julie, with a question just around what challenges have you in your own personal experiences faced or experienced as you were comparing Medicare plans, including Medicare Advantage and traditional Medicare during open enrollment?
Awesome. Thanks, Aditi. Hi, everybody. My name is Julie Balasalle. I work with Aditi at IMALS, but I'm also a volunteer for Cure PSP, which is an organization that supports people living with progressive supranuclear palsy, cortical basal degeneration, and multiple system atrophy. And my mother received a probable diagnosis of cortical basal degeneration in March of 2022. And that is not during the open enrollment period. And so we had no way of anticipating that she would have a fast progressing neurodegenerative 100% fatal disease. So that was probably the biggest challenge. Just even within her disease, progression does not look the same depending on each patient, which I know is not, specific to CBD, but something that was really difficult for us when, she passed away in January of 2023. So when we were reassessing our options, it was really difficult for us to know what the rate of her progression would be. And also, there are so many specialists that were involved in her care that it was really difficult to match them with all the different plans and the options. And some where she had already established care didn't take certain plans that we were looking at, and it was so overwhelming to manage her diagnosis as well as try and plan her care options when I don't think I need to tell anybody on this call, no one tells you how to do this. It's not something that's like inherently known. So, I'm a trained social worker, and I was completely lost. And so I think specifically, for neurodegenerative diseases or other, diseases where progression is, cannot be sort of predicted in a time, way, that was really difficult for our family. And so I think what I took away from that was just the importance of making connections as much as possible with people like the Center for Medicare Advocacy or other advocacy organizations, to try and find resources. Because for us, it was extremely challenging to try and explain to people who didn't understand about our diseases, my mom's, situation, and it didn't fall in the timeline of when we needed to change plans, and which I could have a whole webinar just on the ridiculousness of that. But, just the acknowledgement that, people's health don't lie in this, this neat box of timelines. And as a caregiver, it's really difficult to be able to do all of these things. And, our family, we love my mom, and, we really wanted to do the best we could, but it was so overwhelming that my best advice to people who are navigating this, is to not give up, because it was, and you are not alone in trying to figure out what works best for you and your loved ones who are going through this process. So I don't know if that answered your question, Aditi, but it was not an easy time. And for such a fast progressing disease that my mom had, not everyone progressed as fast as she does. She was diagnosed in 2022 and she passed away in January of 2023. So we made all of this, all of these decisions trying to figure out, what her rate of progression was going to be and what services we were going to need and what specialists and things like that. And it was time, that we didn't have. So.
Thank you for sharing, Julie. And I think I echo all of the sentiments we're getting in chat too. When I say I'm truly sorry for this experience and for your loss. It is intense to lose a parent, to say the least, and to throw in the complications of navigating Medicare on top of that. It makes it even more intense and feels like it's in some ways robbing you of the time that you would like to spend with your loved one. When you were going through that experience of trying to figure out, well, how do I choose this plan and what are the anticipated needs and, anticipated progression, what kind of support did you have around you, whether that was from the medical community or other organizations in the community?
Yeah, we were lucky in that, we had a great provider. Her primary care provider was really helpful, who specialized in her primary care provider was who specialized in geriatric population. So she was very familiar with Medicare, which was helpful. We did talk to some brokers. We did, sort of assess through Cure PSP, just like what different options were. And I spent a lot of time on the CMA website as well to just try and find out more information. It was during COVID, we moved my parents from Massachusetts to Colorado. So there was like the added complication of finding all new providers. And so it was, I think, probably a mismatch of a lot of Google searching, a lot of reaching out to people that I knew in the social work world who did care navigation, which was super helpful. So if you work with an organization who does that, the SHIP, I wish I had known about SHIP. Those also seem like really wonderful resources. But if there's an organization that you are knowledgeable of that, if you have a specific, disease space that you are involved with, they might have some resources as well. It really was sort of like a patchwork of trying to find different pieces to come together. Everything is so siloed, trying to talk to different specialists and trying to figure out which drug, and her prescriptions were changing so rapidly. That was another huge sort of challenge for us, because we didn't know what she was going to need when, and things were changing so quickly that they were like, well, just send us her list. And I was like, the list I sent you yesterday is now different. And so that is like a whole piece that it was like a job. It was a lot. But I think there are resources there to help, and you are not alone. There are people who are in this with you, whether this is your first time or you're trying to navigate all of these changes now. As you can see in the chat and in all of the questions, there's, so many so many people who are in this boat. And so I think resources that like CMA have, or if there's more local resources, I highly recommend taking a deep breath. This is what I had to do a lot myself, taking a deep breath and trying to know that you're not alone and that there are people who are doing this alongside you, even if you don't know them, who have, I saw in the chat somebody who had a very similar experience with a rehab hospital who was on Medicare Advantage. This happened with my dad, actually, not my mom, but he's in an assisted living facility. They wanted to send him directly to a rehab hospital, and they didn't feel, and his primary care doctor felt like he didn't need to be in a hospital, but that he did need rehab. And they would not accept him. But if he had had straight Medicare and not Medicare Advantage, then that would not have been an issue. So they wanted to send him to the hospital for 5 days and then send him to the rehab, even though all of his care providers said that that was not what they wanted. And so there was a third party involved in this. So now I sort of have all this other stuff with Medicare Advantage in my head about just the prior authorizations, like David and Eric were talking about, and now that knowledge of, that's a huge issue, and not something that we knew the first time around when we did this, when we chose that plan for him. So something that we'll continually think about as we launch into the next enrollment period.
Yeah, and it can feel so frustrating to be like, okay, I went through this process, I know so much more, and next year will be easier. And then you get to next year and there's so many changes that you feel almost like a novice going through it again.
Exactly. Yeah.
And I am curious to hear from you, what, if anything, has helped you feel more confident in making decisions as you have navigated Medicare multiple times?
Yeah, I'd say I've gotten a lot more outspoken about it, and being very clear with his providers about what his plan is, and asking about what the impact. And I know that they don't always know, but I didn't know about the rehab situation before, and now I know that, and so that's something that I just continually keep to learn. I also try and remind myself that this is like a moving target that is always like you could just see in this whole presentation that we all just heard. It's like we're supposed to retain all of this information and then adjust and go forward as if it's just as easy as checking a box, when there are real life implications, and our health and our loved ones' health involved. And so I try and like sort of keep that in the back of my mind, that it's not just me. And so when somebody is like, well, didn't you do your research? I just take a deep breath and say, I have done hours and hours of research on this. And I feel for the people who don't have this kind of support to be able to help them through this. That's why I'm so grateful for, social workers and care navigators and organizations like CMA, who are really trying to make this really complicated maze better. And so I think what's made me more confident is just like the blatant, just I don't care anymore. I'm going to do the best thing I can do for my dad. I did as best as I could for my mom, and just really hope that I'm doing everything right. Like I said, I am a social worker, but I feel like a complete novice. No, but there should be a class in school that's like, how do you like navigate this Medicare crazy system? Because it is, something that is extreme. It is not set up for use. It's set up for people to not use it on purpose. And so that's just my own personal opinion. But I think that is, something that I just sort of like fight and just continually want to let people know that they're not alone, and that there are many really wonderful advocates that are constantly every day working to make this system better. And just how grateful I am for all of that. So I really I just thank everybody who tries to help other people with this. And yeah, that's
Thank you so much, Julie, both for sharing about your personal experiences and how you handle this, and also just your general approach to supporting your parents through this. I think that was the perfect note on mentioning the incredible people who offer so much support to others impacted not just by neurodegenerative diseases, but really who are looking to navigate Medicare, make sure that they are making the right decisions for them. So on that note, I would love to turn it back over to Matt and the incredible team at Center for Medicare Advocacy to answer some of the many questions that we've gotten throughout this session.
All righty, thank you very much. Let's pull our panelists back up. Thank you, Julie, for sharing your story here. I think you inspired several people in our chat right now to start doing some work. All right, we have to start, David, I'm afraid, with you because we had many questions about this little shutdown of our entire government and how that might affect, plan finder updates, ship access, etc. So anything you can tell us about the shutdown would be welcome to many of our attendees.
Sure, happy to relay what I know. First, Julie, Aditi, thank you. Julie, sharing your story is so helpful for so many people, and a lot of people go through these types of experiences personally, and if you haven't gone through that personally, hearing from someone who has helps really illuminate everything and highlight the challenges. So thank you for that. With respect to the federal government shutdown, as of midnight last night, our government is closed, which means that roughly most of the federal government's non-essential functions are on hold. The basic running of the Medicare and Medicaid programs should continue, though, including the 1-800-Medicare line, which is a federal contract but not staffed by federal employees. It may be difficult to get help from Center for Medicare and Medicaid Services staff for troubleshooting and things that SHIP counselors and others typically rely on in order to resolve problems. Some of the updates to the Medicare Plan Finder might not be as frequent as we had hoped. Social Security Administration will stay open. They have pledged to get out all their payments. Mail will still be delivered, so people should be receiving their notices and the annual notices of change that Eric mentioned. And just as we've been on the call, I've started to see the Medicare program start issuing guidance to their partners and stakeholders and their contractors about what happens. I mean, it probably isn't a leap to say the longer the shutdown goes on, the more difficulty it's likely to cause for beneficiaries, providers, and everyone else. But just know that some of these basic functions, in theory, are intact and will continue to operate.
Thank you, David.
Matt, I
Appreciate
just
that.
wanted to jump in and say some folks in the chat said that they called Medicare this morning and that the line was answered right away. So that's a good sign,
Yep. Positive.
at least for today.
Right. We'll see in 2 weeks how that goes. We had a practical tip question. This could be for Eric and or Julie, probably. Many people have been asking about what to do if they have trouble navigating the online resources that we've talked about, in particular, the Plan Finder.
Yeah, and I should say I've been seeing a lot in the chat too about the new directory information that's available via the Plan Finder. That is taking people outside of the Plan Finder tool to Medicare Advantage plans websites and is hard to navigate from what people are saying. So yeah, I think the answer is turn to someone you trust in sorting through your options and make a decision. If you have a Julie in your life, that is great to help you navigate all of these difficult decisions. The SHIPs are also available to provide that unbiased support. And then if nothing else, call 1-800-Medicare and ask for information or who you can be referred to for more help. So there is help out there. Please reach out for help rather than feeling overwhelmed. I don't know if you have anything to add, Julie.
I was just going to add the way that I sort of did it was I used a spreadsheet and I just sort of copied and pasted a lot of information so I could just see it all together, like back to back. I also had like a contact log of who I talked to and when and what they said. I always asked for people's names and tried to build relationships with people when I could, whether it was calling Medicare or one of the private insurance plans like United Healthcare, or like the third party plans. so that I had a record, because they would, it was very common that no one knew who I was or what I was doing. So I'd say, sort of as a very practical, not like a game-changing tip, but just one to sort of keep track of the communication and the research that you do, because I read so much, and I couldn't retain all the information at once. So having something that was like that I knew my brain would be able to focus on, was helpful for me. In whatever way that would work for you would be a very, like I said, not life-changing tip, but something that helps to sort of control that chaos is what I would say.
Thank you so much, both of you. If sorry, go ahead, David.
Oh, just going to really quickly about what Eric mentioned about the plan finder and information about Medicare Advantage plan networks. So this was kind of a last minute announcement by the Medicare program. And for this year, they are contracting with a third-party vendor that's collecting Medicare Advantage provider directory information and putting it on the plan finder. But in announcing these changes, the Medicare program said that not all Medicare Advantage plans have data that's shared with this vendor. So in some instances, I guess they will be referring folks back out to the individual plans. There was a rule issued by Medicare that really applies to Medicare Advantage plans for the 2027 plan year, where it's estimated that the data will be a little better. But I think when it comes to the provider directories, my instinct is check directly with the providers, check with the offices of the providers to see what plans they contract with and what plans they will contract with. And even that's not a guarantee that you're going to end up, in a most satisfactory situation. But that's the best thing to do. I would not rely solely on the information on Plan Finder.
Thanks, David. Before I move on to the next question, a lot of people have been asking about the links in the slides. Some of our more esoteric browsers like DuckDuckGo and Safari, you may actually have to copy the link out because of security settings. So just be aware of that. And thanks for raising it, those of you who have. Kata, we have some confusion about MA Medigap and Medicare and the relations thereof and when you can have what.
Yes, thank you, Matt. So yeah, I saw a few questions in the chat about whether you need a Medigap policy with Medicare Advantage. No, you do not. Medigap is just to cover the out-of-pocket costs in traditional Medicare. You cannot have both Medigap and Medicare Advantage. So if you have a Medicare Advantage plan, you should not enroll in a Medigap plan as well. I also saw a couple questions about expansions in specific states, like the birthday rule and others. And it's my understanding that those are just, they're wonderful consumer protections and they're helpful, but they're just for those who already are in a Medigap plan. Those wouldn't help those folks that we were kind of focusing on in our presentation today who are past their 12-month trial period in Medicare Advantage, discover that they have a health condition or providers that they want to see, or Medicare Advantage is just not meeting their needs and they want to switch to traditional Medicare outside of the 4 states, and with Maine, it's even more limited. Outside of those states, it's really not possible for those folks to get pick up a Medigap plan without underwriting, even with the states that have some of these other expansions like the birthday rule. If someone knows of an additional state and an additional new protections, please let me know. But that's my current understanding of the way things work, that those birthday rules are really helpful for those who have a Medigap plan already, but not those who are in MA past the 12-month waiting period.
Thanks,
Hope that's helpful. I know it's a really confusing topic.
I think that clarified some things. If I know we have about a minute left here, but if folks want to stay on, we have about 1,200 people still on for this webinar, which is pretty amazing. Thank you, folks, for the attention here. David, we had some folks in the chat sort of asking, if you had a wish list, what could you do to simplify Medicare and coordinating coverage or improve Medicare versus MA? Like what's your wish list for Medicare?
How much time do we have? I think one of the most important dynamics in the Medicare program right now is the unequal playing field between Medicare Advantage and traditional Medicare. Medicare is becoming more privatized as more people enroll in Medicare Advantage. I think we need to strengthen and shore up traditional Medicare. We need to add an out-of-pocket cap. We need to add dental, vision, and hearing services. We need to add some of the same things that are available in Medicare Advantage, which aren't available in traditional Medicare now. And we can pay for that if we actually use the significant overpayments that go to Medicare Advantage plans now due to manipulation of the risk-adjusted payment system and a quality bonus payment system that doesn't really reward quality. So that's where I would start in trying to strengthen the Medicare program and make things more equal. There's a lot to be done in the Medicare marketplace and the sale of these plans. There were some consumer protections that CMS rolled out a couple years ago that were meant to address some of the incentives for agents and brokers to steer people towards certain Medicare Advantage plans, but a Texas court put that on hold and got pretty much vacated those rules. I would significantly strengthen and fund to a greater degree the SHIP program, the nationwide SHIP program. Medicare beneficiaries clearly need a lot of help. And we mention the SHIPs a lot, and we talk about problems with agents and brokers. I don't want to paint all agents and brokers with the same brushstroke. There are good, honest brokers out there who do the best things for their clients. But we're in an environment where there are a lot of incentives for people willing to follow them to push people towards certain products and away from others. Not all of them do that. I don't want to suggest that that is the case. But the reason that we refer people to SHIP so often is because that is really the only source of unbiased, neutral information where there is not a pecuniary interest in the outcome of your decision. Well, there's a couple things I would start with. There's more, but I can say that for another time.
Thanks, David. We had several questions in the chat about a plan being eliminated. Say a plan's eliminated and the person does not select something new. What happens to them?
They will, I'm assuming it's a Medicare Advantage plan.
Yes, sorry, yeah.
They will revert to traditional Medicare, and they could be eligible. They won't automatically get say a standalone Part D plan. They'll want to enroll in one, and if their plan went away, they should have a special enrollment opportunity to pick one up, but it requires some type of affirmative action on the part of an individual. They have to act to do something in order to get Part D coverage. If their plan goes away, it also very likely triggers a Medigap guarantee issue right. If they can afford a plan and if they want to stay in traditional Medicare, they might be able to pick up a Medigap plan at that point and a standalone Part D plan. If they want to enroll in another Medicare Advantage plan, then they'll have to pick one. They'll have to choose one. I don't know if Kata, Eric, anything you wanted to add to that?
Yeah, you should be receiving a notice. You shouldn't be guessing what's going to happen. The notice should tell you exactly what will happen. And if you don't get that for any reason, make a call to your plan, make a call to a SHIP and ask the question.
Thank you very much, both of you. We have a question sort of specific to the bulk of our audience here. I'm not sure how detailed we can get on it right now, but someone said, my understanding is the majority of the attendees here today are through orgs supporting neurodegenerative diseases. Can anyone speak to what benefits a newly diagnosed patient under 65, new to Medicare, might expect to get? Someone with ALS or MSA or so on.
Well, there's a universe of services that Medicare covers under Parts A and B, and then separately under Part D. And the general test is whether or not something is medically reasonable and necessary. If there are particular services that you're inquiring about or wondering about, I suggest you go to the cms.gov website, and there is a tool that allows you to search by particular service. Whether or not something is covered. And it pulls up, if you type in a particular type of procedure, service, equipment, etc., it'll pull up the rules that are applicable to that, whether or not there's a national coverage determination, local coverage determination, or provision of Medicare manuals that will outline whether or not something is covered. If you're wondering about in general what services might be available to me, I think a lot of organizations that focus on particular diseases or conditions tend to provide a lot of public-facing information about what to expect. Not only like I'm newly diagnosed with something, what does this mean for me, but also a lot of helpful information about what might be available through different types of insurance products, including Medicare or Medicaid, or what to expect if you enroll in a Medicare Advantage plan. I know that's not a complete answer or maybe a satisfactory answer, but that's what I'm able to give now. I don't know, Eric, Kata, Julie, Aditi, if you have anything else to add.
All right,
You,
hearing
you
nothing
covered
else.
it, David. Yeah.
Thank you for that. We probably should mention that 24-month waiting period for folks, just so that they would be aware.
Yes. I saw that too, that some were asking about whether when you have a permanent disability, how long you have to wait to enroll in Medicare, and there is a 24-month waiting period. And I believe that is just a cost-saving measure. There's no health policy reason for that. That's something that we have advocated for eliminating, but in this current climate, don't expect that to happen anytime soon. But yeah, it's really unfortunate that people have to wait that long to get their Medicare coverage to kick in.
And just note, people with ALS specifically can have that waiting period waived. They can get Medicare right away. That was a special carve out that was achieved through advocates on behalf of individuals with ALS, which is great. Now we should work on the rest of everyone else eligible for Medicare based upon disability and get rid of that 24-month waiting period. As Kata said, there's no policy justification other than saving the federal government money while many people go without insurance.
Yes, and thank you for adding the ALS, of course. That
And Anne mentioned ESRD as
and
well.
ESRD as well. Thank you.
Yep. Thank you all for that. I'm going to go big picture for our last one, and sorry to Kata and Eric, it's probably going to be David again. We had several people after your wonderful list ask, what can people do to advocate for these changes? What's the best way to actually try to make something happen? And again, we know right now in this particular climate, that's going to be an uphill climb to say the least. But in general, what can people do to try to make this system better?
Well, I think there are lots of ways to do that. Like Julie, you can tell your story. You can share your story with others, and shared experience can go a long way towards changing things. I mean, Medicare is mostly a federal program, but at the state level, as Kata mentioned, states have the authority to expand Medigap rights. Work with your states to expand the Medigap rights and add to the floor of the federal Medigap rights. Most importantly, your federal elected representatives, the members of the U.S. House, the members of the Senate, let them know what your experiences are and how you think things should change. It's if our elected officials don't hear from us, they don't, then the void will be filled by those who have more direct access to them. So make your views known, whatever they are, share them with your federal elected officials, but there's lots more you can do. And I was struck how Julie was really talking about the community that you can build by working with others and collaborating with others. So there are multiple pathways to try to change things. And I suggest choosing whatever path makes the most sense for you.
Julie, did you have anything you wanted to add to that?
I just wanted to, like I said, I kind of got outspoken. I'm not usually an outspoken person, but I made a lot of phone calls. And I think everything that David said is exactly right. There's a lot of organizations that work on lots of different kinds of healthcare access, whether it's Medicare or some other state based programs. I know in Massachusetts, there's an organization called Healthcare for All that works on a variety of different access issues specific to Massachusetts. And I know there's national programs that do that as well. I know everyone gets a lot of newsletters, but I feel like that's actually a really good way to sort of stay involved and see what actions the organizations are taking and how you can help. A lot of them will have action alerts that you can send to your federal representatives, or, Hill days or state Hill days, where you can go. And I really recommend sharing your story. That more than anything else is when they see the actual impact of these decisions on their constituents, is one of the best tools. It's not the only tool, but it's one of the best tools we have to raising awareness about this, and really talking about ways that we could make better policy that helps people. So that would be my 2 cents.
Thank you very much. Thank you all, in fact. And thanks to the almost 900 folks who stayed on for these extra few minutes here at the end. I want to very much offer my thanks to Aditi and Julie from the Cures Collective. And I'm sorry that we didn't get our third panelist. I know she would have been awesome, but thank you guys for your partnership on this and for your insight. It was just amazing. Fantastic storytelling. Thank you all for attending today. Thank you to the CMA panelists. Stay tuned to our website for information on upcoming presentations. And everyone will receive a recording link once that recording is processed. I'll see about getting a transcript out, because I know some of those folks who use the AI recordings we're trying to share, but it's a one-person situation. So I'll see what I can do about that as well. Thank you all. If there are no final words from anybody, I will end today's presentation. Bye-bye.